This is a sign seen in the right iliac fossa when a patient has a acute onset of pain. Acute onset of pain in the right iliac fossa. Ultrasound showing this sign. What is this sign called? It's called a target sign. Target sign in the right iliac fossa. What do you think of? Common condition. Someone has already partially guessed the answer. It's an appendicitis. This is a target sign of appendicitis. Target sign of appendicitis. So this is what do you mean by a target sign? Target sign is nothing but if you look at an ultrasound report for appendicitis, they usually give non-compressible aperistaltic tube in the right iliac fossa. Non-compressible aperistaltic tube in the right iliac fossa. This is known as target sign. And target sign is classical of the appendicitis, acute appendicitis. So we'll quickly go on to acute appendicitis. So acute appendicitis is a common entity seen between 20 to 30 years. Both male and female are commonly affected. It can occur at any age. Though it can occur at any age. What is the most common organism causing acute appendicitis? Bacteroids is the most common organism causing appendicitis. Bacteroids is the most common organism causing appendicitis. Bacteroids is the most common organism causing appendicitis. What is the classical triad of appendicitis? It is pain, vomiting, and fever. This is a triad of appendicitis. Triad of appendicitis is first pain, followed by vomiting, and then fever. This is called as triad of appendicitis. I hope they have a screen. You can see my handwriting. Pain, vomiting, and fever. Pain, vomiting, and fever. So right over that point, practical circuits. Triad is pain, vomiting, and fever. Pain, vomiting, and fever. It's a triad. This is Murphy's triad. Murphy's triad. This triad's name is Murphy's triad. What are the various signs of appendicitis? What are the various signs of appendicitis? In other words, let's put it like this. What is the first site to have pain in appendicitis? All pain starts in the right iliac fossa, or does it start somewhere else? Usually, first pain is in the periumbilical region, because first pain of appendicitis is a visceral pain, and a visceral pain is a poorly localizing pain. Teeth and terminal. So first pain a patient says will be in the periumbilical region, and then the patient will have a localizing pain to the right iliac fossa. Then the patient will have a pain in the right iliac fossa. Only when the parietal peritoneum is involved, the pain will localize into the right iliac fossa. Otherwise, visceral peritoneum or the layer covering the appendix is a visceral pain is a poorly localizing pain. So there will be a vague pain in the periumbilical region as a first sign. Then only the pain will localize to the right iliac fossa. Okay. There are various signs of appendicitis. I will humbly go ask you to read. Okay. You have the Murphy's sign. Have the rousing sign. Like that, there are many signs for appendicitis which are very operator sign is also there. So I saying so many signs are there for appendicitis. Please go read about all these signs because these signs are also important for the exam. What are the signs of appendicitis? Okay. But what I would like to teach you here is something that is more important for you in the exam in terms of diagnosing the appendicitis. Because the appendicitis presents with the right iliac fossa pain. And right iliac fossa pain can be due to various reasons. I told you one cause already, urinary colic. It can be due to also in young females you can have tuber ovarian diseases, torsion ovarian cyst, tuber ovarian abscess, anything can come. So how will you clinically diagnose a appendicitis pain? Is it just by signs or is there a scoring system to identify it? Alvarado score or mantle score? Mantle score. And a score more than 7 is diagnostic of appendicitis. What are the various things that you see in this score? I will show you. Okay. So right now this is known as mantle score. So what are the various aspects of mantle score? What are the various aspects of mantle score? These are the various aspects of mantle score where you have first is migrating pain. A for anorexia, migrating pain, A for anorexia, N for nausea, T for tenderness, R for rebound tenderness, E for elevated temperature, L for leukocytosis, and S for shift to left. Okay. So M for migrating pain, A for anorexia, N for nausea, T for tenderness, R for rebound tenderness, E for elevated temperature, okay, and L for leukocytosis, S for shift to left. So these are the various scores for mantle score, and the total score is 10, and more than 7 is diagnostic of appendicitis. So M for migrating pain, A for anorexia, N for nausea, P for tenderness, R for rebound tenderness, E for elevated temperature, L for leukocytosis, and S for shift to left. Okay. Total score is 10, and a score of more than 7 is diagnostic for appendicitis. So how will you treat, or what is the investigation for appendicitis apart from this? Getting this off. Okay. So this is the next slide only if you want to get it. So investigation wise, first investigation will be in the form of ultrasound. But the most sensitive and specific investigation is a CT scan. So contra CT scan is most sensitive and specific. Most sensitive and specific is contra CT scan, and a contra CT scan can tell you if there's a complication of appendicitis. What are the complications of appendicitis? Is there an appendicular mass? Is there an appendicular abscess or a perforation? These can be picked up specifically by CT scan. So where resources available, you do a CT scan. Otherwise, ultrasound is more than enough. But in the exam, if they ask you which is more sensitive, your answer will be CCT. CCT is more sensitive. And in good centers, without CT, they are not operating appendicitis. Previously, when I was doing MBBS call, it was clinical examination. We In my hospital, we never used to have ultrasound. Prepare the patient very well. The consultant will come. You would have taken the history and you would present the history to the consultant. The consultant will not ask anything to the patient. Ask the patient to fold the legs, press in the right leg, and goes slowly talking to the patient. The patient might say, I'm having pain, I'm having pain. And suddenly he will remove the hand. The patient will shout with pain. They say, okay, this is appendicitis, we'll operate. So that used to be the way they decide. 90% we had appendix, 10% we had normal appendix also. But then that's how we used to manage appendicitis. Historically. So talking about internship in 2011. So 2011-12, when I did my internship. So in my institution, after 2 o'clock, we never used to have ultrasound or CT. If at all the CT is required, we used to take CT for head injury. Otherwise, appendicitis was a clinical diagnosis. What used to be an appendix for me never used to be an appendix for my friend. So equivocal cases also we used to keep in the case till next day morning. What is the problem? We used to operate. And 90% we used to find appendicitis, 10% the appendix used to be normal. And our pathologist, if you clamp the appendix in the mesoappendix, invariably there will be some congestion. So any pathological report for appendicitis operated, you will see mild congestion seen in the appendix. Whether it is inflammatory or not, doesn't matter. Invariably the report will be mild congestion, some amount of subacute appendicitis seen. So there used to be a time when appendix was eradicated so much, but now I think we are all streamlined to a point where we are considering realistic diagnosis of appendicitis. So when I did my PG and all, the diagnosis, though we had only limited CT available, whenever the diagnosis is in doubt, we used to wait. We never used to operate. And we found that patients responded. An appendicitis patient mostly will slowly deteriorate with time. The pain will not settle unless you operate on it. With antibiotics, though there are now studies saying with minimal inflammation or small abscess, we can treat with antibiotics. But generally, if you have seen these patients before, for a patient to comfortably be managed with antibiotics, the patient should come to you with the first symptom of pain and not self-medicate, manage the pain for 3 to 4 days and then come. Most of our patients will come like that. So though the Western literature says that acute appendicitis, early presentation, small abscess can be managed with antibiotics itself is what they are trying to push in now. If you take the recent edition of Savastin, 21st edition, they have said that mild inflammation, small abscess, less than 2.5 centimeter, antibiotic is enough. But our patients never come to us with a 2.5 centimeter abscess and all. They'll come to us with a full-blown appendix. So if you manage our patients with antibiotic, they will not respond. So this coming on to how we have evolved. So there was a point where we manage appendicitis without investigation. Then we said we do ultrasound. But now we have come to a point where we're doing CT scan for appendicitis, so that we are more specific in managing the patients. Few occasions on opening appendicitis, we have had surprises. I have had Meckel's diverticulum twice, presenting as appendicitis. But usually as a victim in my MS period and in my post-MS period. So I worked as surgery assistant professor for 3 years post-MS period. So I finished my MS in 2016. So till 2018, I was working in Kielpop Medical College in my same hospital as assistant professor. And then 1 year I worked in CNC in hepatobiliary unit before I got my MCH. So as a victim, when I was doing my MS and after my MS also, any adolescent female presenting with abdominal pain, I usually always wait to do imaging to decide this appendicitis and then open, because the chances of having an ovarian cyst, a twisted ovarian cyst used to be very common, or at least a tube ovarian abscess used to be very common. But there was this one patient who came on a Sunday, severe abdominal pain, right iliac fossa pain, classical reboundedness. So much of pain, patient is struggling and already most of the obstetric departments will be full of work, will be full of ops work in the weekend. So you refer an ovarian cyst or someone also in a doubt to the center there. For them to do an ultrasound will take the next day, and probably the patient would have gone further into sepsis the next day. And acute pain, you are always in doubt, and patient is not affordable to do ultrasound in a private hospital also. Being a Sunday, ultrasound is not available in a government hospital where I was working. So reluctantly, we decided, okay, there is a patient who Mantle score is more than 7. But 16-year-old female, chance of appendicitis is still there. We open the abdomen. So again, we put a McMoney incision only. We open the abdomen. Appendix was found to be normal. Appendix was found to be normal. Then comes a question. Appendix is normal. You open the abdomen. So you have to find out why there is a right layer fossa. Unless you find out why there is a right layer fossa, you are not justified in opening the abdomen. Examine the entire distal ileum for Meckel's everything. Meckel's everything also is not. The next normal pathology that you have to look for is tubes and ovary. And with that incision, the tubes and ovary access is little difficult. Already, my assistants, my final year PGs are saying, sir, this is a problem. We have to do a laparotomy further. Let's do a laparotomy. At least we have better access. In this incision, there is no access of any organ. I said, she's a young female. We can't just let her open the abdomen. We will try first to see for ipsilateral ovarian tube and ovary. If it is normal, then we'll see what we can do. Otherwise, no point trying to go a laparotomy. Laparotomy is like blindly swinging the bat, hoping that some ball will connect and go for 6. Okay. So what I decided was, I put a muscle cutting incision on the same appendicectomy incision for around 2 to 3 centimeters, and there was good access. I put my hand inside to feel for the tubes. We found a torsion of the para-ovarian cyst. And but the cyst was deep into the pelvis. It was not coming into the abdomen, into the incision at all. So we have found out the pathology, but we are not able to rectify the incision. Again, there was a stress and a pressure to put a midline lower midline lateral. I said, we have found out now that we have found out the diagnosis. There is no point trying to do a lower midline laparotomy, especially for a young female who is not even started a family. So then I realized, okay, fine. Most young females, an acute ovarian torsion presents the cyst. The chance of cyst to be a benign cyst is highly likely. So what we did was, we took a 10 ml syringe. We aspirated the cyst to see what the content of the cyst is. If the content is going to be clear, it's a simple cyst. So then no problem in aspirating the cyst completely and then delivering the tubes and ovary out. Otherwise, if it is going to be a malignant cyst, then we will decide to do a laparotomy, because a malignant cyst or a hemorrhagic cyst, we have to do a lower midline laparotomy to do a proper surgery. Luckily, on aspiration, it was a clear fluid. 40 ml we aspirated, the size of the cyst decreased. The cyst came through the appendicectomy incision itself. And luckily, we were able to do a cyst excision, preserving the ovary and tubes. We put the ovary and tubes inside, we close the abdomen, patient completely recovered. So this is one scenario where I want to tell you that it is always better to have an imaging, especially when there's a clinical doubt. And if at all you are pushed to a point where you have to open, always have your differential diagnosis in the back of the mind, because if you are going to opt for a surgical career, at least 30 to 40% of the time, you will have surprises. You will have surprises. And you cannot go with a fixed mindset. If I thought, okay, I opened for appendicitis and do an appendicectomy of a normal appendix without looking for pathology and come out, the patient will not recover. Patient will not recover. We ended up doing an ovarian cyst excision, preserved the ovary and tubes. We just reassured the parents that the patient is fine. We had an incidental finding, and then we came out. Ultimately, the patient recovered very well, unalarmingly, and recovered. So, one of the reasons why I also prefer that it is better that we have higher investigations especially in doubtful patients. And another scenario where usually eosinophilic tuberculosis also will present with right layer fossa type. Okay, so, but eosinophilic tuberculosis you can identify with history and clinical presentation. Patient will have history of fever, will have history of cough, will have history of vague abdominal pain and profound loose stools. So it is easy to diagnose eosinophilic tuberculosis with comparison to appendicitis. The reason why I am telling about eosinophilic tuberculosis is usually in your PG period, you will have a spree to pick up appendicitis and operate, because appendix is a PG case. You want to operate the appendix. So especially if you become senior person, if you become an assistant professor, and if you have PGs under you, your PGs will invariably bring 5 to 6 appendicitis on every duty. It is your responsibility to see clinically whether the patient fits into appendicitis or not. So once I had a patient who had a classic history of tuberculosis, comfortably missed and brought to me as a case of appendicitis. Examined the patient. Patient had features of tuberculosis only. I said, this patient looks very vague. We can't open this abdomen and find TB and come out. Because what will happen is patient will have a tuberculous discharge and fistula from the side to open. Looked at the X-ray of the patient, bilateral upper lobe fibrosis were there, and areas of active pneumonitis or consolidation was there. Luckily, the chest X-ray was suggestive of tuberculosis. We didn't do anything. We said this is probably tuberculosis of the abdomen. Waited for CT scan the next day. It was tuberculosis. So always have your clinical correlation in mind and be ready for surprises, because it will never be like what you think. And if you think any procedure or surgery will always be what you anticipate, there is no fun in it. There's no fun in it. Because that's where the role of a surgeon comes. The ability to handle crisis situation. Otherwise, if it's going to be 1 plus sequential, 1 plus 1, then anyone can handle it. This, going back to this topic again. So role of CECT is to identify mass formation and any complication like abscesses in a case of appendicitis. So what is the treatment for appendicitis? Appendicectomy is the treatment modality of choice for any appendicitis, and it is better to do a laparoscopic appendicectomy. It's better to do a laparoscopic appendicectomy. Okay. However, there have been recent guidelines where there's something known as non-operative treatment of appendicitis, where if the patient presents to us at an early stage, or if there is an abscess of size less than 2.5 centimeter, you can give the patients a trial of antibiotics and wait, and if the patient recovers, no need to do surgery. This is a recent concept in the management of appendicitis, that there is a role for antibiotics and there is a role for no surgery also. But this is not practiced, at least in our setup. Maybe in the Western world, they are practicing. But this has come to textbooks. Sabiston 20th edition has given this. So probably next edition of Bailey we might get this. As of now, why should we remember this? If there's a question on non-operative management of appendicitis, there you remember this. Otherwise, appendicitis treatment is laparoscopic appendicectomy. Okay. If out of the blue they ask you non-operative management of appendicitis, is it applicable? Yes. In some patients, you can non-operatively manage. Okay. Non-operatively manage. Now, how will you manage an appendicular mass? How will you manage an appendicular mass? How will you manage an appendicular mass? Appendicular mass is managed. What is an appendicular mass basically? An appendicular mass is nothing but the omentum, the ileum, the appendix are all combined together to form a conglomerate mass. The omentum, ileum, appendix all come together to form a conglomerate mass. Okay, this is body's natural defense. Okay, so why does an appendicular mass happens? Usually after the 5th day of an acute appendicitis, 5th day of an acute appendicitis, or more than 3rd day. Usually on the 5th day, but sometimes on the 3rd and 4th day also of an acute appendicitis. If the patient's immunity is good, if the patient's immunity is good, the body will go for a natural way to control the infection forming an appendicular mass. Now, what will you do when a patient is having an appendicular mass? You do wait and watch. Treat the patient with NPO, Riles tube feeding, or Riles tube aspiration. Sorry, it's Riles tube aspiration, not feeding. Sorry. Riles tube aspiration. Okay. NPO, Riles tube aspiration, antibiotics, IV fluids, and clinical examination. So in clinical examination, what will you do? You will look at the size of the mass, whether it is increasing, whether the mass is becoming an abscess. So this regimen is called, any idea? It's called Oshner-Sherrin regimen. So today I've taught you only about 2 regimens. One is Biscard's regimen. This is Oshner-Sherrin regimen. What is an Oshner-Sherrin regimen? It's a conservative treatment for appendicular mass. Conservative treatment for appendicular mass. Okay. Now, in this treatment, you expect the mass to resolve by itself. Mass should disappear, patient should improve in 1 week. And once the patient improves after 1 week, after 6 weeks, you have to do an interval appendicectomy. After 6 weeks, you should do an interval appendicectomy. This is for a normal course. So, how will you manage an appendicular mass? IV fluid, NPO, antibiotics, clinical examination. If the patient is improving, do interval appendicectomy after 6 weeks. Suppose a patient is not improving, then probably the patient is going to develop an appendicular abscess, which might require drainage. Either surgical drainage or ultrasound guided. Either by surgery or ultrasound guided. So I repeat again. So management of an appendicular mass, the omentum, ileum, and appendix all come together to conglomerate form a mass lesion. That's called an appendicular mass. This is a natural defense of the body against an acute appendicitis. Usually after the 3rd day, we will have an appendicular mass. Okay, and presence at the 5th day. How will you manage an appendicular mass? Not by surgery, by conservative management. The regimen is called Oshner-Sherrin regimen. Once you give NPO, you give antibiotics, Riles tube aspiration, IV fluids, clinically examine the mass. If the mass is going to decrease in size, patient is improving, then you start the patient on orals and do an appendicular surgery after 6 weeks. Internal appendicectomy after 6 weeks. If the patient is not responding, then obviously the mass is now becoming an abscess. Either drain the abscess by ultrasound or by surgery. This is actually management of the appendicular. The management of the appendicular mass. So, what is the most common tumor arising from the appendix? Any idea what is the most common tumor arising from the appendix? Most common cancer arising from appendix is carcinoid. Most common tumor arising from the appendix is carcinoid. Most common tumor arising from the appendix is carcinoid. Okay. And how will you manage a carcinoid tumor of the appendix? Usually, you have to look at the size of the tumor. The tumor size is less than 2 cm present in the tip of the appendix. Appendicectomy is enough. If the tumor is going to be more than 2 cm or is present in the base of the appendix, then you have to do a right hemicolectomy. So, in other words, surgery is the treatment of choice for a carcinoid tumor occurring in the appendix. Adenocarcinoma of the appendix are very rare. Carcinoid is the most common tumor arising from the appendix. So, sometimes there are questions in the exam where they will ask, you have a case of appendicitis, you have operated with appendicectomy. Most of histopathology comes as carcinoid tumor, and they ask you how will you manage. Okay. Not always. What you look at is the dimension of the tumor, whether the margins are okay, and the location. Okay. If the tumor size is more than 2 cm and the margins are not clearly given, no clear mention of the margin. Okay. Tumor of size more than 2 cm, the margins are either unclear or margins are involved, and the location is in the base of the appendix. So, dimension more than 2 cm. Dimension more than 2 cm. The margins are unclear or involved, and the location is the base. These are the indications for right hemicolectomy. So, this is on a post-operative period. Okay, so, your happiness does not end with the good surgery. You have to follow the pathology report also. Okay. So, this is on a post-op. What post-op? Post-op appendicectomy for appendicitis. Suddenly comes as carcinoid tumor. What do you do? This is what you do to decide whether you do a right hemicolectomy.